Welcome to another podcast from Snazzy Surgeon. Hello, everyone, and welcome back. Today, we're really diving deep into, well, one of the most intricate tools we work with, the hand.
Absolutely. It's fundamental.
You're going to unravel its layers, skin, fascia, and really focus on those surgical landmarks that honestly can make or break an outcome. The goal, sharpen our understanding for better precision.
Exactly. That foundational knowledge is it's everything for us as plastic surgeons. Understanding these layers impacts, well, pretty much every hand, procedure planning, incisions, avoiding trouble. It's core stuff.
Okay, let's start peeling back the layers then. The skin on the back of the hand versus the palm, it's remarkably different, isn't it?
Oh, dramatically so. It's not subtle at all.
And that difference dictates so much.
You've hit on a crucial point there. Take the dorsal skin. It's thin, it's pliable, it's anchored pretty loosely by areolar tissue to the deep fascia underneath.
Right, very mobile.
It's very mobile. And clinically, here's the key takeaway. Because the main venous and lymphatic drainage runs dorsally, that's why hand edema nearly always shows up there first.
Ah, okay. That makes sense. It's the path of least resistance, so to speak.
Precisely. It's the hand's early warning sign for swelling.
And those dorsal veins are so prominent too, right? Easy to see.
Absolutely. They're right there in the subcutaneous tissue, making it our standard go-to site for checking venous filling, limb venous pressure on exam. But there's a downside. That same thinness and loose attachment, it makes the dorsum really vulnerable to skin avulsion injuries.
Yeah, you see that, unfortunately. A trade-off for mobility, I suppose.
Exactly. Mobility versus durability.
Okay, let's flip over to the palm then. This is where it gets really interesting for function and, well, the potential for contractures.
Right. The palmar skin is built completely differently. Thick dermal layer, heavily cornified surface. It's designed for grip, for protection.
So much less pliable than the back.
Significantly less pliable. And crucially, it's held down tight to the thick palmar fascia underneath.
How is it held so tightly?
Through these diffuse vertical fibers. They run between the fascia and the dermis, creating this really robust connection. That stability is absolutely critical for gripping things securely.
Makes sense.
And of course, you've got a high concentration of sensory end organs and sweat glands, vital for feedback and maintaining grip.
So knowing all the thickness, the tight adherence, what does that mean for us when we're planning incisions? Seems like precision is paramount.
It really is. You have to understand the relationship between the skin creases and the underlying joints for accurate placement. It's not optional, really.
And the scarring potential.
That's the big challenge on the palm. Scar fixation, any loss of elasticity, it can very quickly lead to contractures and functional loss.
Because it's already under tension on that concave side.
Exactly. Its inherent nature, that stabilizing fixation, its position, it all predisposes it to contracture if scarred improperly.
Which brings Littler's work to mind, doesn't it? His insights on avoiding longitudinal scars across those specific zones.
An excellent point. Littler mapped it out beautifully. He showed where longitudinal scars directly block extension, highlighting those diamond-shaped skin surfaces in each digit.
Right, the ones that bunch up in flexion.
Precisely. The key is those areas cannot be shortened or made inelastic by a longitudinal scar if you want to keep full extension. It's a constant reminder of the mechanics involved.
Okay, moving deeper than the skin now. The palmar fascia itself, that's a fascinating, really resistant fibrous structure.
It really is. It's not just a flat sheet. It's highly organized. You've got longitudinal, transverse, oblique, and vertical fibers all working together. A complex framework.
Let's break that down, starting with the longitudinal fibers. Where do they come from and where do they go?
Okay, so they're most concentrated proximally at the wrist. They mainly originate from the palmaris longus tendon when it's present.
Which is most of the time, right? Something like 80–85%.
Exactly. Around 80–85% of people have one. A good anatomical point to check pre-op. And it's important to distinguish this fascia from the flexor retinaculum deep to it. The fascia's fibers run longitudinally. The retinaculums are transverse.
Got it. So from the wrist, how do they spread out?
They fan out into these flat bundles heading towards each digit. Some minor fibers go superficially to the skin, but the main bulk goes distally into the fingers.
Attaching where specifically?
They attach firmly to the fibrous flexor sheath, and importantly, they also have attachments to the volar plate and the intermetacarpal ligaments right at the sides of the flexor sheath near the metacarpal heads.
Knowing those specific anchor points, the volar plate, the intermetacarpal ligaments, why is that clinically relevant day to day?
Well, it tells you exactly where contractures, like in Dupuytren's, will exert their pull and cause deformity. It guides your release. You need to free those specific tethering points.
Okay, and what about fibers to the thumb or the little finger side?
Yeah, there are longitudinal fibers going to the thumb. They're usually less defined and blend into the thenar fascia. On the ulnar side, they blend into the hypothenar fascia, and that proximal part is where the palmaris brevis muscle attaches.
Right, the muscle that wrinkles the skin there.
That's the one. Helps with grip.
Okay, now the transverse fibers, you said they organize the midpalm and web spaces. What's their significance? You mentioned a potential surprise.
Yes, the transverse fibers. They're mainly in the midpalm and web spaces, lying deep to the longitudinal bundles, and they're kind of interwoven with the vertical fibers forming septa. Skoog actually called this system the transverse palmar ligament back in '67.
And they act as a pulley.
In a sense, yes. They form the roof over the flexor tendons proximal to the digital pulleys. So functionally, they act like a pulley system there.
Okay, so here's the surprise.
Right. Here's the interesting bit. Biomechanical studies showed that cutting just this palmar aponeurosis pulley didn't actually change the work or efficiency of the flexor tendons.
Really? That seems counterintuitive if it acts like a pulley.
It does. But despite that finding, this very structure has been implicated in causing trigger finger.
Huh. So its role might be more complex than just simple mechanics. A bit of a head-scratcher.
Definitely. It challenges our assumptions.
All right, this naturally leads us to the vertical fibers, the perforating fibers of Legu and Juvara. How do these create the compartments we navigate?
Ah, yes, the vertical fibers. Superficially, they run up to the dermis, contributing to that tight skin fixation we talked about. But deep to the main palmar fascia, these vertical fibers organize into distinct septa, the fibers of Legu and Juvara. And these septa create 8 specific compartments in the palm.
8 compartments? What's in them?
You get one compartment for the flexor tendons going to each finger, so it's a 4. Then you have separate compartments containing the neurovascular bundles, along with their accompanying lumbrical muscles.
Okay, so tendons separate from nerves and vessels.
Exactly. These compartments mostly run up to about the mid-palm. Proximal to that, it's more of a common central space. The septa on the very edges, the marginal ones, extend further proximally, closing off that central space.
Is there one septum that's particularly important surgically?
Yes, there's a major septum between the index finger flexor tendons and the neurovascular lumbrical space heading to the third web space. It attaches to the third metacarpal and effectively separates the thenar or adductor space from the midpalmar space.
And knowing these compartments helps during surgery? How?
Oh, tremendously. For things like trigger finger release, sympathectomy, or especially a complex dupuytren's fasciectomy, knowing these septal boundaries is like having a roadmap. It helps you find structures and stay in the right plane.
An internal GPS, like you said earlier. Okay, let's move distally now into the fingers. We have those other fascial bands, Grayson's and Cleland's ligaments.
Right. Important for protecting the neurovascular bundles within the digits themselves. Grayson's ligaments are volar toward the palm side to the bundles, and they're quite flimsy, actually.
Flimsy, okay.
In contrast, Cleland's ligaments are much stouter, much stronger, and they lie dorsal to the neurovascular bundles.
So one volar, one dorsal, sandwiching the nerves and arteries.
Exactly. Together, they create a protected channel for the digital arteries and nerves as they travel down the finger. Essential to identify and preserve them.
Absolutely. Now, for orientation in the palm, especially near critical nerves, Kaplan's cardinal line is such a useful landmark, a real clinical pearl.
It really is invaluable. Immanuel Kaplan gave us these surface lines to help pinpoint key structures without extensive dissection. The cardinal line is perhaps the most famous.
How do you draw it again?
You draw a line from the apex of the first web space, the space between the thumb and index finger, straight across to the distal edge of the pisiform bone.
Okay, web space, apex to distal pisiform.
Correct. Then, to make it useful, you draw 2 longitudinal lines down from the fingers. One comes down from the ulnar side of the middle finger, the other from the ulnar side of the ring finger. Where these cross the cardinal line tells you where things are.
So what do those crossing points signify?
Okay, the intersection of the cardinal line, and that line from the ulnar side of the middle finger that marks the location of the median nerve motor branch.
The recurrent motor branch, critically important.
Absolutely, the one you don't want to injure. Then, the intersection of the cardinal line and the line from the ulnar side of the ring finger that pinpoints the hook of the hemate.
A key bony landmark.
Right. And finally, the ulnar nerve motor branch. It lies on the cardinal line itself, about equidistant between the hook of the hemate and the pisiform.
Wow. That really simplifies finding those structures. Makes surgery safer, more efficient.
It truly does. Less guesswork, less exploration. It's a beautiful example of applying anatomical knowledge directly to surgical practice.
What a fantastic deep dive. We've really journeyed through the hands layers today, the contrasting skin types, that incredibly complex palmar fascia with all its fibers and compartments, the digital ligaments, and finishing with a practical landmark like Kaplan's line. It just reinforces how vital this detailed anatomy is for us.
It absolutely does. And perhaps a final thought for you to consider. Given this intricate fascial anatomy, the septal divisions we discussed, how might subtle variations between individuals affect how things like infections spread? Or maybe influence the pattern or progression of Dupuytren's disease?
That's interesting.
And what does that imply for our preoperative planning?
Yeah.
Maybe even for imaging, it encourages us to look even closer, doesn't it, before we even make an incision?
Definitely food for thought. Always more to learn and consider.
Always.
Thank you for listening to our podcast. See you in the next episode.